Here we are on to, I believe it's video number 5. I may have lost count, but it's somewhere along those lines. And we are talking about the hospitalization of the infant. Again, our first priority is keep the baby safe. Um, Probably a board's question is going to be something like crib rails are down and you need to do A, B, and C. What would you do first? Put the crib rails up. We need to make sure that that baby's routine is as consistent to what goes on at home as possible, because the child will adapt better. Any familiar objects, a blanket. A lot of moms will say, oh, I'll take that blanket home and wash it, because kids' security blankets get like totally gross. But it's their blanket and it's their germs and it's their gross, and that is not the time to send it home to be washed. Sometimes they'll ask you to leave a shirt or something that belongs to the mom that has her smell, and that's really helpful. And of course, you want the parents to stay there as much as possible. With the infant, you also don't want to criticize or judge the parents. Like, gosh, why didn't they bring the baby to the hospital sooner? Aren't they dumb? They didn't know he was sick, or didn't they see that leg hanging off there? Why do you think he was crying? You don't want to do any kind of judgment. And the nurse's job is to nurse the entire family. The baby that's sick, the mom and the dad, the siblings. If the child is hospitalized for a long time, that's going to cause animosity with the siblings. And so a nurse needs to anticipate that and find some way to help the parents deal with their other children. And children start to feel guilty, like, I feel bad that my baby sister's sick, but I'm also mad because my parents are gone all the time. So you have to help them come to grips with those kinds of feelings. Hospitalization of the toddler is a little bit different. They scream, um, they rebel. Their first thing they do is protest. Um, it, Mom leaves the room, they're screaming. You come in with any piece of equipment, and they know that something's going to hurt. So they start to fight. Then they start to feel feelings of despair, like they can't believe this is happening to them. Then if it gets really bad and we don't take good care of them, they'll start to detach, and we got to make sure that that doesn't happen. So again, just like the infant, you want to have them to have things that they could bring from home, toys, blankets, whatever is appropriate. Parents in the room. No matter what age the child is, you want the parents to be in the room and maintain as many habits from home as possible, as far as sleeping and eating and foods and that kind of thing that are possible. Preschool age child is a little bit better, because they usually understand that they're sick and that you're there to help them feel well. They have a better understanding of that. Doesn't mean they're not sad. But they can be taken away from mom. And when I say mom, I mean the caregiver. They can be taken away a little bit more often and with less anxiety. They really fear that you're going to hurt their body. They think if you're going to give them a shot, I don't know what they imagine, but I think they imagine aliens running through their bodies. They believe that they're sick because they were naughty, and that maybe this is a punishment. A good way to get a toddler or a preschool age child to talk is to role play with them with dolls or toys or blocks or Legos, and they'll start telling stories whether you're paying attention or not. And they don't have any concept of time, so they might be admitted at 2 o'clock in the afternoon, and at 5:30, when you haven't even gotten blood test results yet, they're like, okay, I want to go home now. So you really have to work with them on the conceptualization of time and how long it takes things to happen. Then there's the school-age child. They can be separated from their parents for a short amount of time, but you still want to encourage the parents to be there. They understand things well enough to fear what's physically going wrong with them. They might ask you if they're going to die, even on something as simple as, an appendectomy or a broken leg, because they'll say, my cousin Jimmy's aunt, second time removed, had an appendicitis attack and it ruptured and she died. By school age, they start to remember that kind of stuff, so you have to be on it with them and really answer their questions well. They're going to attempt to be brave, and in attempting to be brave, they might not tell you things hurt or bother them. So you have to watch for those subtle nonverbal cues. Their play has to be industrious. It's very, very important. Anything you can give them that they think they're helping you will be good. Labeling things, maybe writing cards for people, drawing pictures that you can hang on the bulletin board, anything like that. You especially want to have a same-sex caregiver, especially for female children. You do not want to have a male nurse taking care of a female child. It's very frightening to them, and they're going to want to know everything that's going on, so you make sure you provide really good education. Communicating with a family. The communication must happen at the developmental level of the child. So if the child is in first grade and they're having an appendectomy, you're not going to talk about putting an 18-gauge needle, blah, 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 this kind of anesthesia, normal saline running at 100 mLs an hour, CT pre-op. That's too much, too many words. So what you have to do is you have to say, Johnny, I know you've had a tummy ache, and we're going to make your tummy ache feel better, and this is what the doctor's going to do. And you can do things like draw a little picture on their belly or on your belly or on the mommy's belly and say, doctor's going to make a little cut here and a little cut here if it's laparoscopic, and we're going to go in there and get your appendix out and maybe show a picture of the appendix. And again, at the level of the child's development, you can fill in all the details with the parents later, but you want to talk to the parents very specifically. The child at their level and then the parents very specifically later. And be very, very careful of body language. When you talk to someone, there are things that you communicate without ever saying a word. And we're going to go over these in class, but here's some examples. I'm not going to say what I think these are, but I am sure that you do. So in class, we'll come up with one sentence for what each of those mean. And how many times do you do this? I laugh at my husband all the time because his favorite position is to stand and watch people with his arms across his chest. He's the nicest person on the planet, but he doesn't look like he's nice. He looks like he's bored and put out. So be very, very careful what you communicate without your words. Excuse me. Next topic is medication administration, and we're going to go over some actual examples. I'm thinking at this point in your careers, you already know how to figure out a safe dose, and that's going to be a big part of what we do, is figuring out safe dose for children. When a child is prescribed a drug, safety is the most important thing. Because of how children absorb and distribute medications, you have to be very, very careful that, first of all, they're given enough of the medication, and certainly that they're not given too much of the medication. There is a fine line between a therapeutic dose and a toxic dose. There's also, you'll see in children's medications, you will see what they call an off-label use. And this is when a drug is given for something other than what it was put on the market for. Or it's off-label if there's not a pediatric dose. Now that doesn't mean that it can't be given. It just means that you have to check it out. An example of that is they give beta blockers to children with ADHD. Beta blockers work in children totally different than they work in adults, and it's really interesting. I had a lot of kids at camp who were on beta blockers, and the first couple times I thought, wow, this kid's on 100 of metoprolol twice a day. They couldn't even have a blood pressure. But guess what they do? Because the beta blockers affect them differently. So when you look in the pediatric drug guide on Nursing Central, you're not going to probably see metoprolol as an ADH drug. You might now. Um, it's been a while since I've been at camp. It's been like 3 years. But so you have to check with the physician and verify the order to make sure that you can give it. But it doesn't mean that you cannot give an off-label use drug. I love this slide because I like pictures, and it kind of talks a little bit about what's going on in the body and why it's so important to have the right medication, right time, right route, right, all that stuff. Children have way more water in their bodies than adults, so they absorb drugs differently. Their pH is different, and how they metabolize things is a lot different. How they excrete drugs is different. When you get down to the chemical processes, protein binding, that kind of thing, it makes a difference on how drugs come through the body, then hit the kidney and are taken out of the body. If they stay in the circulation too long and then you give more, you're going to overdose the child. And then there is the distribution of the drug. The reason chemotherapy doesn't work in adults for brain cancer is because chemotherapy is poison and it won't cross the blood-brain barrier. But in children, their blood-brain barrier is not mature. The good part is, I suppose, they can give chemotherapy if they have brain cancer. The bad part is drugs can get to their brain that shouldn't get to their brain. So you have to be very, very careful with that. And then, of course, their liver's very immature, so drugs that are metabolized in the liver, it can get into the body a whole lot faster and increase the metabolism of them. Older children who are athletes and moving around, they're going to use the medication quickly, and so they might require some higher doses. So I think this slide is a really good slide because it really does explain in 3 sentences or less all of the necessary components of absorption of medication. We're going to talk about this more in class. This is a pediatric dosage calculation based on body surface area. They don't really use this anymore, but you can see you take the height of the child in centimeters and their weight, and across here it gives you their body surface area. And if you look at some drugs, they are dosed by body surface area, or can be. You can use this chart for doses of some drugs. They don't really use those very much anymore. Now it's mostly by milligrams per kilogram. So we are going to do some of those dosage calculations. If you haven't already done this, again, the pediatric dosage is milligrams per kilogram, and then the max dose in 24 hours, the minimum dose, and that's how you figure your safe dose range. So between now and class, if I were you, I would look up in your dosage calculation book how to do pediatric dosage calculation, but be assured that we will also go over it in class. Here is a sample problem for you. And again, we'll go over some more of these in class. This talks about IV piggybacks and figuring an infusion rate. And again, we'll go over some more of that in class and on into the next lecture also. So that concludes week 1. This is very fast because it's video and there's not questions, there's not interaction. So replay the video as many times as you need to. Again, we're going to go over this in class. We're going to do some case studies. We're going to do some pediatric calculations, talk about our cultures, where we're from, and try and solidify this information. So I hope this is helpful to you, and I look forward to having you in class.